Good morning, one and all. This is Dr. Ganesh, Assistant Professor from Department of ENT. The today's topic is anatomy of the larynx as well as the tracheobronchial tree. So the points which we're gonna see in this class today is the anatomy. Basically, the cartilages of the larynx, the first and foremost thing, that the joints formed between the cartilages, the membranes and the ligaments of the larynx, cavities of the larynx, as well as the mucous membranes over the larynx, lymphatic drainages of the larynx, as well as the spaces, the functional spaces which were there in the larynx, especially the mucosal folds as well as the vocal folds, then the muscles of the larynx, their nerve supply, then the development of the larynx, trachea, bronchi, as well as the lungs, then the functional aspects of the larynx, especially the protection of lower airways as well as the phonation and speech, then a part regarding the anatomy of your tracheobronchial tree. So moving on further, the cartilages of the larynx. Larynx is, as we said, it's a fibrocartilaginous structure which has a few paired cartilages as well as few unpaired cartilages. The unpaired cartilages of the larynx are three in number, namely thyroid cartilage, cricoid cartilage, as well as epiglottis. And we have three paired cartilages, namely your arytenoid, corniculate, and cuneiform cartilages. Basically, we have three unpaired cartilages, and these cartilages may be of various types. The types of the cartilage, especially hyaline cartilage, thyroid cartilage, cricoid cartilage, and most of the arytenoid cartilage, except at its tip, they are of hyaline cartilages. The applied aspect over here is this hyaline cartilage will go for ossification or calcification at later point of time, which may undergo ossification, which may produce fracture in cases of elderly people. This is the applied aspect with respect to hyaline cartilage. So the point over here is this thyroid cartilage may undergo ossification or hyalinization at an elderly age group, and there are many chances that when the patient is attempting for accidental strangulation or suicide, this thyroid cartilage will go for fracture, producing lethal damage to the patient. Then the other type of cartilage which was mentioned over here is the elastic cartilage, especially the epiglottis, corniculate, and cuneiform and tip of the arytenoids. They all are fibroelastic in nature. The most important aspect or the most important thing with respect to the fibroelastic cartilage, it has its recoiling capacity. So the other example for a fibroelastic cartilage is the auricular cartilage or the pinna, okay, where they have this recoiling capacity. So epiglottis, corniculate, and cuneiform, they have this elastic nature. Coming to the individual cartilages, in subsequent slides we will see about the individual cartilages. First and foremost thing, the unpaired cartilage, which is the hyaline cartilage, as I said earlier, is the thyroid cartilage. This is the largest laryngeal cartilage which has two alae. Okay, so it has two ala which meet anteriorly in the midline and form at an angle. Okay, so in case of adults, the angulation is somewhere around 90 degree in case of males, whereas in case of females it is 120 degree. The posterior part of this ala give attachment to the vocal folds. That's why the voice or the resonance of the voice is different in case of males as well as in case of females, because of the angulation which is 90 degree in case of males as well as 120 degree in females. They have slight different sides of attachment, making the peculiarity of this voice. Moving on to the second cartilage, which is your cricoid cartilage. This is a ring-shaped cartilage. Cricoid cartilage is the ring-shaped cartilage, which is otherwise called as a signet ring cartilage. Signet ring cartilage. Okay, it has a narrow anterior arch and a broad expanded posterior lamina or an arch. Okay, so it is of signet ring or ring-shaped. It is the only complete cartilage of the larynx, and the anterior arch or the lamina is very small, whereas the posterior arch or the lamina is relatively broader, over which articulate the arytenoids. Moving on to the third cartilage, which is the third unpaired cartilage, which is the epiglottis. Epiglottis is a leaf-like or yellow elastic cartilage. It is a leaf-like or it is called as petiole shape. Okay, and it is yellow elastic cartilage. Again, it's an elastic cartilage. It is yellow elastic one. The epiglottis forms the anterior wall of the laryngeal inlet. When you have this laryngeal inlet, the epiglottis forms the anterior wall of this laryngeal inlet. Petiole shaped stalk-like process of the epiglottis attaches to the thyroid angle. Okay, the part of the epiglottis also attaches to the thyroid angle. So this is a diagram which was showing the three unpaired cartilages. First and foremost thing, we have the epiglottis, where it is leaf-like or petiole shape. Then we have the thyroid cartilage, which is again it has two ala. The two ala meet in the midline, which is 90° in case of males, whereas 120° in case of females. Then we have the cricoid cartilage, which is the complete cartilage or single signet shaped cartilage, which has a narrow anterior arch and a broad posterior arch. In between these cartilages, we have the presence of membrane, which will come for the subsequent slides. Then the parts of the epiglottis, the anterior surface of the epiglottis is attached to the body of the hyoid bone by hyoepiglottic ligament. Okay, so it is attached with the hyoid bone by a ligament which is called as hyoepiglottic ligament. This hyoepiglottic ligament divides the epiglottis into suprahyoid as well as infrahyoid components. Okay, then moving on to the paired cartilages. The first and foremost thing is your arytenoid cartilage. Arytenoid cartilage is pyramidal in shape and has the following parts. It has a base. Okay, since it is a pyramid, it has a base, so which articulates with the cricoid cartilage by cricoarytenoid joint. Then you have the muscular process. The muscular process provides attachment to the intrinsic laryngeal muscles. Then we have the vocal process. Vocal process give attachment to the attachment for the vocal folds. Then we have the apex. Apex, it articulates with the corniculate cartilage in the aryepiglottic fold. So we have a base, you have a muscular process, you have a vocal process as well as a tip. Then moving on to the second paired cartilage, which is called as corniculate cartilage. The other name for the corniculate cartilage is cartilage of Santorini. Cartilage of Santorini. This articulates with the apex of the arytenoid cartilage. Okay. Then the third cartilage, which is there in the aryepiglottic fold, which is again a paired cartilage, is the cuneiform cartilage. The other synonym for the cuneiform cartilage is cartilage of Risberg. Cartilage of Risberg. It is shaped something like a rod-shaped cartilage, and it is situated in the corniculate cartilage, situated in close proximity with articulates with the corniculate cartilage in the aryepiglottic fold. So this is the posterior view of the larynx, which is showing the cartilages as well as the ligaments. We have the epiglottis, we have the other cartilages, especially your arytenoid cartilage. The arytenoid cartilage has this muscular process which gives attachment to the muscles. Then we have the vocal process which gives attachment to the vocal folds. Then the other cartilages, the cornu of the hyoid bone, as well as the superior horn of the thyroid cartilage, other cartilages, all this can be seen over here in this diagram, especially from the posterior aspect. Okay. Moving on to the joints. So far we have seen about the cartilages. Then we have three paired cartilages and three unpaired cartilages. Now these cartilages, they form joints. So what are the joints? The first and foremost thing is the cricoarytenoid joint. That means the self-explanatory joint which is found between the cricoid cartilage as well as the arytenoid cartilage. That is the cricoarytenoid joint. This is a synovial joint, and it is formed by the base of the arytenoid and the facet of the upper border of the cricoid lamina. So this is a synovial type of joint, where the articular surface is the base of the arytenoid as well as the facet of upper border of the cricoid lamina. And two types of movements are possible in case of synovial joint. One is your rotatory movement, the other one is the gliding movement. The second joint which is seen over here is the cricothyroid joint. It's a synovial joint formed between the inferior cornu of the thyroid cartilage and facet of upper border of the cricoid cartilage. So that is cricothyroid joint. Cricothyroid joint. Moving on to the membranes and ligaments of the larynx. Membranes and ligaments of the larynx. We have few extrinsic membranes which are outside on the outer surface of the larynx. Few intrinsic membranes which are within the confines of the fibrocartilaginous framework. The extrinsic membranes are thyrohyoid membrane between the thyroid cartilage and the hyoid cartilage, which is the thyrohyoid membrane. Then we have hyoepiglottic ligament. That means between the hyoid bone and the epiglottis, which is called as your hyoepiglottic ligament. Then we have cricotracheal membrane, cricoid, between the cricoid cartilage on one side and the tracheal rings on the other side. This is the cricotracheal membrane. These three, so thyrohyoid, hyoepiglottic as well as cricotracheal membrane, they form the extrinsic membranes and ligaments of the larynx. Moving on to the intrinsic membranes or intrinsic ligaments of the larynx, we have cricovocal membrane. Between the cricoid cartilage and the vocal folds, they form, which is called as your cricovocal membrane. Then we have the quadrangular membrane. Subglottic foreign bodies sometimes get impacted in the region of conus elasticus. The region between the vocal cords, immediately in vicinity below the vocal cords, are called as conus elasticus, and it is the narrowest part of the glottis, which is the subglottic region. So subglottic foreign bodies sometimes may get impacted in the conus elasticus. Then we have one more applied anatomy, which is called as cricothyrotomy. That means the incision is made in the cricothyroid membrane so as to secure the airway. Any airway obstruction above the level of vocal cord due to tumor of foreign body can be quickly, easily, and effectively bypassed by piercing the cricothyroid membrane. Which is called as cricothyrotomy. This is one more view which is showing the sagittal section of the larynx. The first and foremost thing which is very prominent over here is the pre-epiglottic space. The pre-epiglottic space is otherwise called as pre-epiglottic space of BIHER, which is bounded above by the hyoepiglottic ligament, anteriorly by the thyroid membrane, posteriorly by the epiglottic cartilage. So it's a triangular fat-filled space. The applied aspect over here is the suppose if there is some lesion or if there is some supraglottic growth, this may easily bypass the epiglottics and may come in, sit over in the pre-epiglottic space. So if there is fixity of this pre-epiglottic space or the pre-epiglottic space of BIHER, what is the applied aspect over here is the staging differs. Suppose if there is no involvement of the cartilage, then the staging differs. This makes the treatment option or the outcome, surgical outcomes, as well as the radiotherapy outcome of the patient in question mark when we have to analyze properly about the pre-epiglottic space. Pre-epiglottic space is otherwise called as pre-epiglottic space of BIHER. Then one more lateral view which was showing the other superior con, the ala of the thyroid cartilage as well as the cricoid cartilage. Inferior con of the thyroid cartilage can be seen, or the oblique line can be seen, superior con can be seen. Then the cricothyroid joint can also be seen nicely in this diagram. Then we also have seen cricothyroid ligament, which we were talking a few minutes back. Then the thyrohyoid membrane between the thyroid cartilage and the hyoid bone, which is suspended over here. Then we also have superior tubercle for thyroid cartilage. There's one more tubercle which is called the superior tubercle, which is for the thyroid cartilage. Then one more sagittal section, again showing the membranes of the larynx, especially your cricovocal membrane, cricothyroid membrane, as well as cricotracheal membrane, which is between the cricoid cartilage and the tracheal rings, between the tracheal rings, which is called as cricotracheal membrane. These are the lateral view of the larynx after removing the right lamina of the thyroid cartilage. Once you have removed the lamina of the thyroid cartilage, what we have seen is the triangular shaped retinoid cartilage. It has the base which is attaching to the posterior lamina of the cricoid cartilage. Then you have the muscular process, then you have the vocal process. Okay, so the vocal process gives attachment to the vocal folds. The vocal folds in turn goes and gets attached itself to the posterior lamina of the thyroid cartilage, whereas the muscular process gives attachment to the various muscles which were there in the larynx. So what are the cavities of the larynx? They have the inlet, laryngeal inlet. Laryngeal inlet as such is a cavity. Then we have vestibule, we have ventricle, we have saccule, then we have subglottic region, vestibular folds, vocal folds, and glottis. Okay, all these things, they forms the cavities of the larynx. This is a cadaveric section showing about the various cavities which were seen in the larynx, especially the vestibule, the vestibular fold, the ventricle, then the vocal fold, ventricle, which is seen over here, space which is in front of or above the level of the larynx. Then we have the vocal folds, true vocal folds. Then we have the ventricle, which is seen over here. Then the subglottic region and trachea. This is one more coronal section which was showing the various spaces with respect to the larynx. You have the supraglottic region, we have the glottic region, You have the subglottic region, where all what are the spaces can come, which is shown in the diagram. So the applied anatomy over here is laryngocele. This is an abnormally enlarged and distended saccule that contains air. Okay, retention cyst is obstruction of the duct of the mucous glands in saccule, which causes retention cyst. Laryngocele is laryngocele foreign bodies. Most of these are subglottic and supraglottic in region and lie above the level of oral vocal cords. Why? Because the pediatric nerve is as such very narrower. So most of the time what is happening, because of the narrowed air chamber below, whatever was the foreign body, it tries to get stopped over there. That's why it is supraglottic region, narrowest part of the larynx. Rhizoglottis is the narrowest part of the larynx in adults, whereas in infants the narrowest part of the larynx is in the subglottic region. If you able to remember, in case of this subglottic stenosis, the classification which is followed is Mayer-Cotton grading system for subglottic stenosis. This is indirect laryngoscopic examination view of the larynx, which is showing the oropharynx and the laryngopharynx. On the midline structure, you can see the dorsum of the tongue. Then we have seen papillae, glossoepiglottic ligament or fold, which is called as glossoepiglottic ligament or fold. Then we have epiglottic tubercle, you have the epiglottis. Then on either sides of the epiglottis, you have the space which is called as the vallicula. Then we have the true presence of vocal folds, which may, again, the superficial one is the false card, below is the true card. Then the space between the vocal folds and the piriform fossa, which is marked over here, is the vestibular fold. Then we also have a band which is connecting the epiglottis with the arytenoid, which is called as aryepiglottic fold. Vocal processor attached to the arytenoid, then onto the epiglottis. Okay. Then we have the corniculate cartilage as well as the cuneiform cartilage. The rings of the trachea are seen in the subglottic region along with the vocal process of the arytenoid. Lymphatic structure, lymphatic drainage. Most of the lymphatics drain into the level 1, 2, 3, 4 level group of lymph nodes. Then spaces of the larynx, we have the pre-epiglottic space, which is called as pre-epiglottic space. Of BIHER, we have the paraglottic space as well as the Rinke space. The functional divisions of the vocal folds are separate. Then we'll be seeing in the subsequent classes. Then we also have phase difference between the amount of voice generation and the amount of voice which is perceived by the individual. You have the phase difference. Pre-epiglottic space can be divided by the carcinoma of the supraglottic larynx and the base of the tongue. So pre-epiglottic space is the one which is readily getting cancer or malignant spread easily. Then Rinke's edema. Rinke's edema is nothing but edema of the Rinke space resulting in fusiform swelling of the membranous vocal folds. Mucous, coming on to the third topic, which is the mucous membranes of the larynx. Epithelium of the mucous membrane is ciliated columnar except over the vocal folds and the upper part of the epiglottis and the aryepiglottic folds where it is stratified squamous. It lines the larynx loosely except over the posterior border of the cricoid cartilage. True vocal cords and corniculate cuneiform cartilages cannot be seen normally. Okay. And the mucous membranes, mucous glands are abundant on the epiglottis posterior part of the aryepiglottic fold. These are the few reasons why, even if the cycles are not coming to the patient, they feel comfortable because mucous glands are abundant in the epiglottis and there is no obstruction in the airway. Lymphatic drainage. Lymphatic drainage goes to the supraglottic group of lymph nodes, especially lymphatic is drained into upper deep cervical lobes through the thyroid membrane. Then infraglottic drains into the prelaryngeal, which is the Delphian node, and the pretracheal group of lymph nodes. The glottic lymphatic drain into the vocal cords, and lymphatic drainage of the vocal cords as such are very scanty. Hence, glottic carcinoma rarely shows metastasis. Spaces of the larynx, we have seen the pre-epiglottic space, which is called as the pre-epiglottic space of BIHER. Anterior surface, the anteriorly you have the upper border of the thyroid cartilage and the thyroid membrane. Then superiorly we have the hyoepiglottic ligament. Posteriorly, we have the infrahyoid epiglottis. Then inferiorly, we have the thyroepiglottic ligament. Communication, it laterally communicates with the paraglottic space. Invasion of the epiglottic space is by the carcinoma of the supraglottic as well as from the base of the tongue. These two are the cancers. Cancer in the supraglottic region as well as from the base of the tongue can be easily invaded into the pre-epiglottic space. Then the paraglottic space on either side of the glottis. It communicates with the pre-epiglottic space and is bounded by the anterolateral thyroid cartilage and the cricothyroid membrane. Inframedial, which is by the conus elasticus. Medial, you have the ventricle and the quadrangular membrane. Posterior, we have the anterior mucosa of the pyriform fossa. Okay. So the growths invading the paraglottic space destroys the cricothyroid membrane as well as the present in the neck. The ventricle tumors in the paraglottic space then spread transglottically. Vocal cord tumors involving the thyroarytenoid muscle invade the paraglottic space and then into the subglottic and the extralaryngeal region. Lateral supraglottic tumors can travel to the subglottic region through the paraglottic space. Pyriform fossa tumors can come into the larynx and fix the vocal cords to the posterior part of the paraglottic space. This is the very important applied aspect over here. Then we have the Reinke space. Reinke space is the potential space which has scanty subepithelial connective tissue and lies under the epithelium of the vocal folds. It is bounded above and below by the arcuate lines, anteriorly by the anterior commissure, posterior by the vocal process of the arytenoid. The space between this is called as the Reinke space. Reinke's edema is the edema of the Reinke space, which is resulting in fusiform swelling of the membranous vocal folds. So this is a diagram which is showing the Reinke's space, which is there in the between the epithelial layers of the vocal folds, and this is the fusiform enlargement of this region is called as Reinke's edema. Reinke's edema. Muscles of the larynx, we have few intrinsic muscles, we have few extrinsic muscles. So of the intrinsic muscles, we have vocal cords, adductors, abductors, tensors, relaxers. On the laryngeal inlet, we have openers and closers of the larynx. All these are intrinsic muscles of the larynx. Then we have few extrinsic muscles of the larynx. Then also we also have nerve supply of the larynx, especially your recurrent laryngeal nerve as well as the superior laryngeal nerve. Coming on to the intrinsic muscles of the larynx. The intrinsic muscles of the larynx are vocal cords. The abductors of the vocal cord. The only abductor of the vocal cord is the posterior cricoarytenoid muscle. Posterior cricoarytenoid muscle is the only abductor of the larynx. Then we have few adductors of the larynx, especially your lateral cricoarytenoid, interarytenoid, transverse as well as oblique arytenoid, thyroarytenoid, lateral cricoarytenoid, interarytenoid as well as thyroarytenoid. Tensors, we have cricothyroid muscle, which is the important tensor muscle, which is there as the intrinsic muscle of the larynx. Then we have relaxers, we have vocalis and thyroarytenoid muscle, which is forming the internal compartment. So the only abductor of the larynx is the posterior cricoarytenoid muscle. Openers for the laryngeal inlet, we have thyroepiglottic as part of thyroarytenoid muscle. Then we have closers, interarytenoid region, which is oblique part, then aryepiglottic, posterior oblique part of the interarytenoid. Then we have the extrinsic muscles. Extrinsic muscles, again, they are divided into elevators and depressors. Elevators, primary elevators are stylopharyngeus, salpingopharyngeus, palatopharyngeus, and thyrohyoid. Secondary elevators are mylohyoid, digastrics, stylohyoid, and geniohyoid. Depressors, we have sternomyloid, sternothyroid, and omohyoid. Okay, all these three muscles, they form the depressors of the extrinsic muscles of the larynx. The origin and insertion, posterior cricoarytenoid, as the name suggests, it originates from the posterior surface of the lamina of the cricoid cartilage, then insertion into the arytenoid, front of the muscular process of the arytenoid. And what is the action? The most important action and the only abductor of the vocal cords is the posterior cricoarytenoid. Then we have lateral cricoarytenoid, again starts at the upper border of the cricoid cartilage and it attaches to the muscular process of the arytenoid process and it attacks the vocal folds. Transverse arytenoid, or otherwise called as interarytenoid, back of one arytenoid and its muscular process. So the transverse arytenoid or interarytenoid, back of one arytenoid process into its muscular process. Then the back of other arytenoid process and its muscular between the levels of the arytenoid, which is called as your transverse arytenoid or interarytenoid. Again, the action is adduction of the vocal folds. Then thyroarytenoid external part, lower half of the thyroid angle, anterolateral surface of the arytenoid cartilages. Then it attacks the vocal folds. Cricothyroid, which is between the cricoid cartilage and the thyroid cartilage, anterolateral surface of the cricoid cartilage and the lower border of inferior corner of the thyroid cartilage is the insertion. It lengthens the vocal cord. Means it is the tensor of the vocal cord. It is the tensor of the vocal cord. Thyroarytenoid internal part, which is otherwise called as vocalis muscle. The site of origin is from the lower half of thyroid cartilage and its attachment to the lateral surface of the arytenoid vocal process, and it shortens and thickens the folds. Thyroepiglottic are part of thyroarytenoid muscle, ligaments of the lower third of the thyroid angle, margin of this epiglottis. Then the action is opening of the laryngeal inlet. Last few muscles, we have the oblique interarytenoid muscle, which is the back of the arytenoid process of the arytenoid process, especially over the muscular process, and its attachment is to the opposite or apex of the opposite interarytenoid. It closes the laryngeal inlet. Aryepiglottic or oblique interarytenoid back of the muscular process is the site of origin as well as margin of the epiglottis. They form the insertion. It closes the laryngeal inlet. So we have seen about few openers and closures of the larynx. This is the diagrammatic view which is showing the various muscle fibers and the line of attachment of each of these muscle fibers. All the muscle fibers will have its own origin, own insertion, as well as its own blood supply. Again, intrinsic view of the larynx, which is on the lateral view, showing the various muscles, especially your aryepiglottic, thyroepiglottic, lateral arytenoid, all posterior cricoarytenoid. Posterior cricoarytenoid, again, I am saying it is the only abductor of the vocal folds. All other muscles are adductors or tensors. Lateral view of the larynx showing cricothyroid muscle, cartilage, and the ligaments. So this is the cricothyroid muscle. What it originates from the posterior lamina of the cricoid cartilage and attaches to the lamina of the thyroid cartilage. So this is the site of origin as well as insertion of this cricothyroid muscle. We have the vocalis muscle between the muscular process of the vocal folds and the posterior lamina of the thyroid ala. Okay, then thyroarytenoid, as the name implies, self-explanatory. Also, we have the posterior arytenoid, or otherwise called as posterior cricoarytenoid, between the two muscular process. Then transverse interarytenoid. All these things which we have seen has been diagrammatically put. Nerve supply of the larynx, it is by the vagus nerve, the motor supply and the sensory supply. The recurrent laryngeal nerve is the one which is giving the sensory motor supply to the entire larynx. The recurrent laryngeal nerve is divided into two parts. The recurrent laryngeal nerve on the right side, superior left recurrent laryngeal nerve, as well as the right recurrent laryngeal nerve. On either side, you have one. So the left recurrent laryngeal nerve as well as right recurrent laryngeal nerve. Then on the superior laryngeal nerve is divided into external and the internal laryngeal nerves. The cricothyroid is the only intrinsic muscle that is innervated by the superior laryngeal nerve, not by the recurrent laryngeal nerve. This is the this one. So we have the divisions of the this one. We have the external as well as the internal. Then we have the superior as well as the internal superior laryngeal nerve, which is going over here. Then we have the internal laryngeal nerve. We have the external laryngeal nerve. Then we have the right and left recurrent laryngeal nerve. The left recurrent laryngeal nerve has a longest course, is wounds around the arch of the aorta. Then it comes it ascends along with the subclavian. It goes into the tracheoesophageal groove. Then it innervates the sensation over the supraglottic subglottic as well as the infraglottic compartments. So moving on to the second division, which is the embryological development of the larynx. I have mentioned the source as well as the structures. For the laryngeal mucosa, it is the endoderm of the cephalic part of the forehead. For the laryngeal cartilages, it is the mesenchyme of the branchial arches, epiglottis from the hyoepiglottic ligament. Then upper part of the thyroid cartilage from the fourth branchial arch, then the lower part of the thyroid cartilage, cricoid cartilage, corniculate, and the cuneiform, they all from the sixth branchial arch. The intrinsic muscles of the larynx, they all develop from the sixth branchial arch. Infant larynx, there's a slide which is showing about the infant larynx. The position is little bit higher, which is situated higher. The vocal cords lie at the C3, C4 level during swallowing, and it goes up to C, and during swallowing it goes up to C1, C2 level. In adults, the vocal cord usually lie at the C5 level. The nasopharyngeal channel, the epiglottis and the soft palate forms the nasopharyngeal channel for the breathing during suckling. Infant can simultaneously swallow as well as breathe. This is the peculiarity with respect to the infant larynx. So infant can breathe as well as swallow simultaneously by the nasopharyngeal channel. The milk passes over the dorsum of the tongue and the sides of the epiglottis, while breathing occurs through the nasopharyngeal channel formed by the epiglottis and the soft palate. That's why the baby can easily feed as well as breathe. Cartilages, the laryngeal cartilages in the infants are soft and it is very collapsible easily. So the epiglottis, it is omega shaped. Arytenoids are relatively large and cover significant posterior part of the glottis. Thyroid, the thyroid cartilage is a little bit flatter. It is not going for the Adam's apple. Then the cricoid cartilage, the diameter of the cricoid cartilage is smaller than that of the glottis. Then the cricothyroid and the thyroid spaces, they are very narrow. Tracheostomy in infants, cricothyroid and the thyroid spaces are not applicable landmarks, especially during tracheostomy. The size of the larynx of an infant is smaller and has a narrower lumen. Okay, the narrowest portion of the larynx in children, it is the subglottis. Subglottis is the narrowest portion of the larynx in case of children. Edema in this region occur at the expense of this lumen. Growth of the larynx, the first birth of the laryngeal growth starts at 3 years of life, and the larynx grows in width as well as the length. The laryngeal congenital anomaly, the first spurt of the laryngeal growth is with 3 years of life. So obvious the need for any airway surgery in certain congenital anomaly. The second spurt occurs in during adolescence. The thyroid angle develops and the Adam's apple become prominent and conspicuous, especially in adult males. Position, the larynx usually descends from its higher position. The vocal cords descend to the C5 level. Okay. Moving on to the second important division, the functions of the larynx. The functions of the larynx are protection of the lower airways. Okay, larynx is otherwise called as the watchdog of the lungs. Whatever was the foreign material, whatever was the material which is apart from the air, if it comes in contact with the laryngeal surface, it tries to make cough reflex and it barks it away. That's why larynx is rightly called as the watchdog of the lungs. Also, it helps in phonation and speech. It also helps in respiration as well as fixation of the chest during the movements of respiration. So protection of the lower airways. We'll come for the individual one. The sphincteric closure of the laryngeal opening. They during swallowing and the food entry into the air passage is prevented by the closure of the following 3 successive sphincters. So no food or vomitus can enter, especially the laryngeal inlet, the false cords as well as the true cords. Then the cessation of the respiration protects the airway, because complete cessation makes when the food comes in contact with the oropharynx, the reflex is generated by the afferent fibers of the 9th nerve, which cesses the respiration temporarily. Then we also have the cough reflex. Coughing dislodges as well as expels the foreign particle that comes in contact with the respiratory mucosa. Larynx acts as a watchdog of the lungs, and it immediately starts coughing or barking at the entry of any foreign body. Phonation and speech. Aerodynamic myoelastic theory is the which deals about the voice production. Like a wind instrument, larynx produces voice. The speech is divided into 3 phases. The pulmonary phase, it creates the energy flow with the inflation of the lungs and expulsion of air. The energy flow is started with inflation of the lungs and expulsion of the air. It provides a column of air to the larynx. The subglottic air pressure is generated by the exhaled air from the lungs with the help of contraction of the abdominothoracic muscles. Then we have the laryngeal phase. The air pressure opens the adducted cords and small puffs of air are released. Vocal folds vibrate to create the sound that is modified in the next space. So the small puffs of air are released, the vocal folds are getting vibrated. This is the most important phase, and the vocal fold vibrations are not as a result of laryngeal muscles. Vocal folds are adducted, and the pressure of the moving air causes vibration of this elastic vocal folds. Then we have the third phase, which is called as the supraglottis phase or oral phase. The laryngeal sound that is modified in the supraglottic or the oral phase is considered a unique individual sound. Words of sentences are formed by the muscles of the pharynx, tongue, and the lips and the teeth. The vibration of the vocal folds produces sound, which is amplified by the mouth, pharynx, nose, and the chest. The modulator action of the lips, tongue, palate, and the pharynx teeth converts this sound into a speech. So you have this modification which is happening at the level of the supraglottis. The intensity and the pitch of the sound. The air pressure produced by the lungs control the intensity of the sound. So whatever was the lungs intensity or the air pressure, it controls the intensity and the pitch of the sound. The frequency of the vocal fold vibrations control the pitch of the sound. Different frequencies are produced with change in length, breadth, elasticity, and extension of this vocal folds. Moving on to the last topic, which is the anatomy of the tracheobronchial tree. Few slides over here. The first and foremost thing we'll see about the trachea, tracheal cartilages, mucosa, bronchopulmonary segment. What is epitracheal bronchus and what is the caution which has to be taken during epitracheal means the trachea, as we know, in the tracheal rings, it starts from the first tracheal ring below the cricoid cartilage between the cricotracheal membrane, and it goes up to the level of the carina, where the two trachea divides into two, forming two major bronchus. The epitracheal means above the artery. It is the right upper lobe bronchus that passes over the right pulmonary artery. The left upper lobe bronchus passes under the left pulmonary artery. Caution during bronchoscopic biopsy, applied anatomy. A deep bronchoscopic biopsy, more than 5 mm cup forceps for the epitracheal right upper lobe bronchus divider or the secondary carina can involve the right pulmonary artery and result in disastrous bleeding. So when you are dealing with the biopsy taking from the epitracheal bronchus, especially from the right upper lobe, you have to be very cautious. Then generation and the order of the bronchopulmonary segments. Trachea is the 0th generation, mainstem bronchi is the first generation. So we have right and left. Right accounts for 55 to 60% of the total parenchyma. Then we have the second generation, which is the lobar bronchi, right upper, right middle, and the lower lobes. Whereas in case of left, it is the left upper lobe, lingular, and the lower lobe. Then the lobar segmental bronchi, which is the third generation, 10 segmental lobules, bronchopulmonary segments on the right side, whereas it is 9 on the left side. So we have totally 19 bronchopulmonary segments. Then lobular bronchioles, first airway segment, less than 0.7 millimeter in diameter. They are 10 to 14 generations of the bronchi. So you have first generation, which is the mainstem bronchi. We have the second generation, which is the lobar bronchi. We have the third generation, which is the lobar segmental bronchi. Then the first airway segment, which is the lobular bronchioles, forming all the generations of the tracheobronchial tree. So this is how the lobes and the nomenclature and the segments of the bronchopulmonary vascular has been mentioned when we are dealing with the patient, especially during their investigations as well as the management. This is the diagrammatic representation of the bronchopulmonary segments in the tracheobronchial tree. You have the right mainstem bronchus, left mainstem bronchus. Then we have the upper, lower, and middle lobe bronchus. Whereas in case of left, which is the left upper lobe and the left lower lobe with the lingular bronchus. Okay, the carina is mentioned in the picture over here. This is the lateral view of the lung showing the bronchopulmonary segments, where we have the apical segment, where we have the anterior segment, superior segment of the lingular bronchus, then the inferior segment, then the apical lower bronchus, posterior basal, as well as lateral basal. The lateral view of the right lung showing the bronchopulmonary. We have the apical, anterior, posterior, medial segment of the middle lobe, lateral segment of the middle lobe, and the anterobasal, apical lower, and the posterobasal, and the lateral basal. All these things has been rightly marked over here. The right main bronchus is shorter, wider, and nearly vertical than the left. Therefore, inhaled foreign bodies are more common in the right mainstem bronchus. Aspiration is common into the posterior bronchus of the right upper lobe. A deep bronchoscopic biopsy we have from the epiatrial bronchus of the right upper lobe divider can result in disastrous bleeding. So this is the aspiration, which has aspiration into the posterior bronchus of the right upper lobe patient in coma in the right lateral position. So this is how you introduce the bronchoscope, try to aspirate from the right upper lobe bronchus. And this is the also scenario which may cause disastrous bleeding if it is not taken care of. This finishes the class with respect to the anatomy of the tracheobronchial tree as well as the anatomy of the larynx. Thank you for patient listening. Thank you one and all. Thank you all.